Outside, I would like to thank Arvind Eye Care System, especially Dr. Hemalata Madam and Dr. Manohar Babu sir, to invite me to a part of this CME. So I'll be talking on wide field imaging and ultra wide field retinal imaging. So the traditional fundus cameras which we have usually will capture only up to 30 to 50 degrees of the retina, that is the posterior pole. So the peripheral retina most of the time remains undocumented. So as you can see here, the first diagram is around 30 degree and the second diagram, the 50 degree of the retina. And you can see the peripheral, most part of the retina remains undocumented. So why is documentation important? Okay. Is there a laser point? So why is documentation important? Because for management, monitoring and follow-up of the retinal diseases, we need documentation for medical teaching, patient education and counseling, medical legal aspects, and telemedicine. So whatever the peripheral retina, whatever you cannot be documented on the routine fundus examination, routine imaging can be still assessed with indirect ophthalmoscopy. But again, the documentation remains difficult, and also the assessment is difficult in children, non-cooperative patients, and poor mydriasis. And color retinal charts remain a reasonable preference for documentation of the peripheral retinal findings. But again, those charts varies in between two observers and also depends on the drawing capabilities of the examiner. Then quantification remains a major problem. So diabetic retinopathy study was the first study which made an attempt to capture more of the peripheral retina as compared to the central 30 to 50 degrees. It captured up to 75 degrees of the retina. So this is the standard 7 field photography of the DRS study. However, this was the montaging techniques. What are the problems with montaging techniques? It depends on good patient cooperation, fixation stability, and is often time consuming. And also peripheral optical phenomena and artifact effects are there, which also makes montaging sometimes difficult. So this is one individual. We should thank him. Actually, this is his name is Douglas, Mr. Douglas Anderson. He's a Scottish engineer actually. On the left side is his young 5-year-old son who had lost his vision because of retinal detachment. So his son had undergone regular eye examination prior to the detachment, but the pre-existing lesions could not be diagnosed on time. Obviously, because in a small child, often it is difficult cooperation. So he was the person who thought after his son had gone blind in one eye that something should be done to capture the peripheral retina. So his field was engineering, so he took up it as a challenge. And although before him, many people have tried a few techniques, those were not successful. So something called using something called spherical ellipsoid mirror. The previous engineers told it may not work, but he has tirelessly worked on that. And in 1992, he has launched the first Optos fundus camera. And thanks to him, now we can image almost up to 200 degrees of the retina. So this is a very important personal history for him, which has inspired him to go ahead and discover or invent a wide field imaging system. So coming to the definitions, DSCR.net defines ultra wide field images at least 100 degree of view of the fundus. However, recently a consensus of experts defined the terms. So wide field means up to the from the posterior pole up to the posterior margin of the vortex vein ampulla. Whereas ultra wide field means in a single capture you have to beyond the posterior up to the anterior to the vortex vein ampulla, up to the ora serrata if possible. So this is a comparison of so this is a comparison same two eyes of a patient in a normal standard 30 to 50 degree. You can see only this much of the retina, whereas in a wide field imaging we can see the peripheral retina also. So what are the different wide field imaging systems currently available? We had the RADCAM, which was used for mainly for ROP screening. It has a contact and non-contact system. Then we have the Spectralis Heidelberg. Then we have the Claras, which can capture up to 130 degree of the retina. in a single click. Then Optos, which can capture up to 200 degrees of the retina, which is approximately 82% of the retinal surface. Then there is another system called Mirante, which was launched in 2019. It can give up to a view of 163 degree of the retina. And another system recently launched as IDEN, which gives a field of view of 90 degree in single exposure and up to 160 degree with mosaic function. So this is the comparative picture which I was telling. So this is with that, if you examine with an indirect ophthalmoscope up to 20 degree in a single field, 30 degree of the fundus you can see with the standard fundus cameras, and some fundus cameras give up to 50 degrees. We can see so much of the peripheral retina remains undocumented on imaging. This was the DRS study which tried 7 field images, and it could cover up to 75 degrees. Then we have the REDCam which can cover up to 130 degree. The Claras can go up to 130 to 150 degree, and Optomap currently has the highest field of capture, the single click, which is up to 200 degrees. So these are the different systems, images of the different systems we are talking about, and these are some of the represented image. There is some difference in the color. So in Optomap or Optos, you get something called pseudo color. This is an image from Claras, this is from Iden, and this is from Mirante. Okay, so the most of the true colors will be there in Iden and Claras, whereas in Mirante and Optomap, the color is slightly, they have some greenish hue. So this is what the advantage of Optos I was talking about, an ellipsoid mirror. So it creates a virtual scan point within the eye that is behind the iris plane. So the ellipsoid mirror creates a optical system which takes a virtual scanning point which is behind the iris. So from here it can scan up to 200 degree of the retina. So before going to abnormal findings, what are the normal findings we can see in an ultra wide field imaging? Because previously we didn't have access to the wide field imaging. Most of the peripheral retinal findings which we used to document or see in indirect ophthalmoscopy, we used to consider maybe they are abnormal. But ultra wide field imaging in normal eyes have shown that even they can have a ground glass appearance. Sometimes even microaneurysms can be seen in the retinal periphery. And in high myopes, you can even see an avascular retina in the periphery. So we should remember this. Even in normal retina, these findings can be there. So coming to the utility, the most important clinical condition which we come across in day-to-day retina practice is diabetic retinopathy management and its management. So this is the most common case we come across in our OPDs in India. So previously, traditionally, the diabetic retinopathy was managed with only the posterior pole findings, as you can see here. But now you know that even the peripheral retina is affected in diabetic retinopathy, and the lesions in the peripheral retina are as important as in the posterior pole for diagnosis, classification, as well as follow-up of diabetic retinopathy. So as I was mentioning, in screening of diabetic retinopathy, you can see this is the standard 7-field DRS study which we have used. Even beyond that, now the wide field imaging can pick up. You can see the peripheral retinal CNP areas and the new vessels here. So it can pick up to almost 10 to 15% more cases by using ultra wide field imaging. And also the peripheral neovascularizations and CNP areas can be picked up. So this is one concept called predominantly peripheral lesions, which was introduced by Silva et al. This is the standard ETDRS chart, ETDRS 7 standard field in DRS study. So they have tried studying the lesions outside this 7 field and classified the lesions into predominantly peripheral and predominantly posterior. So the eyes which had more than 50% lesions outside this 7 field, as you can see here, they were classified as predominantly peripheral lesions. They found that the patients who had more these eyes with predominantly peripheral lesions had greater risk of progression of diabetic retinopathy in the future, and also if they undergo vitrectomy, the risk of rebleed is higher in these patients. Also, in treatment of diabetic retinopathy, now wide field imaging has helped us to find out the exact CNP areas, and there is a concept of targeted retinal photocoagulation, which is used by some of the physicians where targeted retinal photocoagulation is done. So in that case, our wide field imaging gives a good idea or where to image. Where to do the laser. So you can see here the outside this area full CNP areas, and in this picture you can see the posterior pole is spared almost and only the peripheral retina is lasered, and this will help to reduce the collateral damage in diabetic retinopathy lasers like color and contrast sensitivity. So this is one of the strategies which some people use. So again, for surgical planning in diabetic retinopathy, also this is useful. If you have a wide field image, you can see if there is a TRD, how far is the TRD from the macula, and is the macula involved or not. And if you are doing a planning a surgery, sometimes with the indirect ophthalmoscope or 90-day examination, when you see in the OPD, there will be vitreous hemorrhage and other findings. We cannot get a wholesome picture of the retina. So the moment we see it in the wide field image and the photograph, we know even the plane of surgery dissection where it will be easy to pick up the membranes. All this pre-surgery, you can do the planning and it helps us. And also for explaining to the patient, show the picture and tell him what is the status, compare between both the eyes. So this is the status of this eyes and the macula is involved or not. So we can always give a visual prognosis also to the patient for surgery. So again, PRP follow-up, we can see if there are any gap areas left, you can easily pick up on a wide field imaging, whereas in a standard 30 or 50-degree imaging, you can see mostly the posterior polloid. The PRP marks are hardly seen. Only maybe 1 row or 2 rows will be seen. Whereas in wide field imaging, you can see the things in fill-in PRP. Even for teaching the residents and the fellows, we can show this is the area you have to do laser. You can mark them and give them, show them. If there are fibrovascular proliferations, usually we'll instruct to stay away at least 2 disc diameters away from the. So this gives a better idea how far you can even draw on the image and show this is this much extent you should come and do the laser and don't come close to the fibrovascular membrane. So this gives a very easy understanding of our treatment procedure. Again, add laser I was telling, you can see you can easily pick up the areas and post laser. Even for the patient, sometimes the patient will come and tell, I already had undergone 2 sittings, 3 sittings, 4 sittings of laser. Why do you need to do laser? So once you take the photograph, you can easily show this image to the patient and explain to him that, see, this is the status. These areas are still gap. We'll do the laser 1 more sitting or 2 more sittings. So it gives a better understanding to the patient as also. Sometimes, despite PRP, you can land up with a recurrent vitreous hemorrhage in the patient. If you do an FFA, you can pick up the CNP areas and additional NVs. So again, it helps in our planning. So coming to venous occlusions again, most of the peripheral CNP areas are under-assessed in vein occlusions, and wide field imaging gives a better understanding and documentation of those CNP areas. It helps in reducing, and these CNP areas are a reason for recurrent VH, progression to NVG, and recurrent or persistent macular edema. So again, targeted retinal photocoagulation is being tried in retinal vein occlusion, where you can go and laser those areas. And one more concept is the macular edema, which is seen in retinal vein occlusion. Even some physicians, even in diabetic macular edema, if it is not responding to the conventional anti-VEGFs or other lasers, grid laser or focal laser, you can look for the peripheral CNP area. So sometimes if you go and do targeted laser, those macular edema can come down. So that is also useful in many cases of non-responding CME in retinal vein occlusions or diabetic macular edema. So as you can see here, this is a case of vein occlusion. You can easily pick up the peripheral CNP areas. So this is again looks like a well lasered case, but with a vein occlusion inferiorly. But once you do an wide field imaging, you can see the CNP area. So this area needs additional laser. So coming to pediatric disorders, the Coats disease, FEVR and RAP are the common disorders we see in India. And in this disease, we know the primary pathology lies in the periphery. Now, in pediatric age group, the imaging is very difficult. Even fundus examination is difficult. Sometimes we need to do it under anesthesia. So the child may not be cooperative. The pupil dilatation, again, sometimes is a problem in some of these disorders. So in ROP, if there is a plus disease, the pupil may not dilate. So if you have a wide field imaging system, even through a small pupil, and uncooperative children also, within a single clip, we can take the images. And it gives a lot of information which we cannot get in the clinics while examination, and we'll have a very rush in the OPD, timing for examination, everything. So one click gives a lot of information and helps in better management and follow-up of these cases. So you can see here in a Coats disease, you can easily pick up these peripheral avascular areas, the bulb aneurysms and the perivascular leaks and the NVs. This is another case of adult Coats disease, where you can see the peripheral avascular areas and the abnormal vessels in the periphery. You can laser those areas. The recurrence of the lesions and also vitreous hemorrhage in these cases will be those peripheral CNP areas. So this is a case of FEVR. Again, you can see tractional detachment here and macular tract. And here you can see an avascular retina and abnormal vessels here and leak in the late stages. So all these cases, a single click will give lot of information and aids us in, assist us in better management of these cases. So in ROP, as I was telling, RETCAM is the conventional thing which has been used for a long time. It gives up to 130-degree coverage, but again, it's a contact procedure and also requires a lot of skill to do it actually. So even the technicians who are doing it, they need to go through a training procedure because holding the probe and taking a correct image is slightly difficult. So whereas Optos, they've started a new technique called flying baby position, where you can just hold the baby in front of the Optos camera and then take an image in a single click, and it gives a beautiful image. In ROP, you can see this is a plus disease, and after injection, the plus disease regress. So what is the advantage? You can see the posterior pole as well as the peripheral retina in the single image, which gives a better idea of the overall disease state. Coming to uveitis again, uveitis cases also, most of these cases, uveitis may have again poor mydriasis because of posterior synechiae. So again, on this case, the wide field imaging is an advantage, and also it helps to monitor the progression of uveitis, the recurrence of uveitis, and also if there are any complications like retinal detachments which develop in the periphery. This is a case of leakage where you can see the pinpoint leaks in the periphery. So all these things can be easily picked up on ultra wide field imaging. Again, this is a case of ocular toxocariasis with a lesion in the periphery and macular drag. So in white dot syndromes, again, classically, most of the time you will see the white dots in the posterior pole and around the mid periphery, but some of these lesions can have also, some of these conditions can also have lesions even in the peripheral retina in acute phases. Again, wide field imaging, especially with autofluorescence, gives a better option to follow up after during management of these patients. Most in uveitis, sometimes because of autofluorescence, we can easily pick up the activity of the lesions. And in the periphery also, we can see if there are any active lesions easily in autofluorescence. Previously, we used to resort to your ICG or what do you call FFA for these cases, but we have autofluorescence now, which can easily take care of this follow-up of these cases. Similarly, in vasculitis, like I was discussing about retinal vein occlusions, again, Eales disease and another retinal vasculitis like tuberculous vasculitis, most of these cases, you can easily pick up the CNP areas and laser them, and then you can follow up these patients easily. Coming to retinal dystrophies, again, most of these retinal and choroidal dystrophies patients, they have poor fixation and poor vision, nystagmus, photophobia, and most of them are children. Again, as I mentioned, like in ROP and other pediatric conditions, these conditions also, imaging is very difficult with the conventional techniques. So here in a wide field imaging, it will give an overall view of the retina at the same go. So you can see a case of Leber's amaurosis where you can see a macular coloboma and peripheral pigmentary changes. This is the case of gyrate atrophy. All these findings can be easily picked up. Now, Stargardt disease, another condition which we come across commonly in our day-to-day practice of among the retinal dystrophies, one of the common findings we see. So Stargardt disease initially was considered to be only involving the posterior pole, but Klofas et al. With ultra wide field FAF shown that it can also involve the peripheral retina. So they have in fact classified Stargardt disease into 3 types. Type 1 with only posterior pole findings with no peripheral findings. Type 2 with posterior pole atrophy with some flex in the peripheral retina. And type 3 with atrophy in the posterior pole as well as the periphery. So this is also helps in better diagnosis and management of this congenital dystrophies also. So coming to tumors, again, it helps in diagnosis and documentation of the tumors, planning the management, following the course and monitoring the complications. So in some cases of choroidal metastasis, sometimes the metastasis can be in the extreme periphery. Again, these patients will come with multiple other systemic conditions and the mydriasis, uveitis also they can have. The pupil dilatation, media haziness, media may be hazy. They might have cataract. So if you have a wide field imaging, the peripheral lesions can be easily picked up sometimes. Again, a differentiation between choroidal melanoma and pigment nevi also can be done easily with your wide field imaging. You can follow up these cases by measurement of the tumor size and overlying pigment changes you can monitor, and also the tumor size on follow-up you can monitor. And then you can easily differentiate between the two. This is a cases of retinoblastoma, as you can see here. This is one lesion nasal quadrant, and this is an heel lesion. So classification of retinoblastoma, international classification which we follow routinely. There are the size of the lesion is important. Then you have the distance from the optic disc and the macula is important. The size 3 mm or more or 3 mm or less, distance from the optic disc 1.5 millimeter, from the macula 3 millimeter. So all these things, when you are examining the patient children with an indirect ophthalmoscope, it's mostly what you call objective measurement. Now, when you have a picture, we can easily sit down, use our tools in the imaging system and measure and give a correct diagnosis. And it also helps our this thing from the medical oncology physicians also to get a proper diagnosis and plan the management. Also, during follow-up, we can see how much the lesion has reduced in size. Vitreous seedings can be easily picked up. Subretinal fluid is important in the classification. So how far is it from the lesion? All those measurements can be easily done in a wide field imaging. So again, another retinal detachment and peripheral lesions. Again, you can easily pick up the retinal breaks, which sometimes on normal imaging we cannot pick up. Again, for explaining to the patient, we can always show this is the cause of your detachment. And whenever retinal detachment comes, always we advise the patient, other eye also should be examined. Or even the vision is 6/6, you might have lesions in the other eye. So that helps in better understanding of the patient also. So if you are telling me I'm going to do laser in the other eye today, patient will tell, I have come with detachment in the left eye, why are doing laser in the right eye? So once we have the image in front of us, if the other eye has some lesions, most of the time the lesions will be symmetrical. So all these things help in better management and explaining to the patient. So these are some peripheral lesions we can picked up after laser. Also doing the laser, also you can show to the patient what has been done to the patient. Even for the residents and the fellows, if you have the image in front, you can tell this is the area you have to laser, how many rows you have to give. If there is a large 360-degree lattice with some holes, which area you have to go and join to the ora serrata. So all this helps in better teaching also and better management of the patients. So these are some miscellaneous cases. 2-3 slides. I'll just finish. Case of CMV retinitis, we can see these lesions. So most of that, we manage most of the cases of CMV retinitis now with intravitreal injections. Actually, the systemic treatment is very costly and also patients cannot afford, and also side effects. So if they are having only ocular lesions, we try to manage initial 1 month with intravitreal injections. So weekly twice or weekly followed by weekly once. So these pictures, when you have it in front of us, gives a better understanding and follow-up of the patients. From the previous visit, if you compare the image, you can see whether new lesions have appeared or not, if the lesions reduced in size or not. And also during the follow-up, you can see if there is retinal thinning and future breaks or anything is there or not. So all these are very important in management. This is again an example of leukemic retinopathy, where you can see pre-treatment and post-treatment, the results. This is a case of CSCR, chronic CSCR. You can see if you have a standard photograph, you can only pick up the posterior pole here, but here you can see nicely the fluid, because of chronicity, it has gone down vertically because of gravitation, and it can easily picked up on wide field imaging. So this is one of our cases, patient with bilateral endogenous endophthalmitis. She had lost one eye because of endophthalmitis. We could not salvage. Other eye, we had done a vitrectomy and retina was good with just some macular atrophy was there. And she had undergone a cataract surgery. So we are following her up. So she has a poor mydriasis and not much cooperative for fundus examination. So 1 month after the cataract surgery, even though she was examined in the OPD, we always tend to take fundus image. So to my surprise, on the fundus image, I could pick up a retinal break. And then I went back and compared the image 1 month back. It was not there at that time. So this is a recent break which has developed, and immediately we had done the laser on the same day. So all this wide field imaging, even in all cases, we try to take images, and only taking the image is not enough. You have to go and evaluate also. The main utility will be once you go and analyze and try to find any additional findings. That's where it lies the importance. So other systems we have ultra wide field OCT. All these are the OCTs which are available now, ultra wide field OCTs, and uses in retinal detachment, pathological myopia, peripheral retinal degeneration, and choroidal pathology. So this is an example. This patient had a choroidal retinoschisis in the periphery. If you do an OCT in the macula, you will miss that. But in the periphery, if you do, you can easily pick up the retinal split here. And wide field OCT angiography is another option which Renu sir had presented. Most of the conventional ones are 8x8 or 12x12. Now we have the 24x24 also. We can go up to somewhere up to the arcade. We can scan and find out the CNP areas and other lesions. So to summarize, wide field imaging is useful for fundus examination in children, uncooperative patients, and poor mydriasis. It has scope of being used as a screening tool for the peripheral retina, as I have shown multiple examples, and automated screening in various studies, and telescreening is being used. Patient counseling, it is very important, and also the documentation. However, one of the drawbacks will be high cost. Most of them cost above 70 lakhs and above. So artifacts is also some problems like other systems. Thank you.